Thank you. Good morning, everyone. I'm going to be starting with some general statements, and also I will be referring to some principles and concepts that inform how we organize or manage live donation generally.
Brilliant. Tunde, could we ask you to open up your slides to slideshow, if you could? Be easier for people to see. Thank you.
Yeah, sorry about that. Yeah, so I would like to just make some general comments, which I think will be helpful to explain what I'm going to be saying later on. And I will start with the statement, which we all know about, that as living donation or living transplant is the best treatment for patients with end-stage renal failure because it offers optimum patient and graft survival. It also offers recipients shorter time on dialysis if they're on dialysis, and also shorter time on the transplant waiting list if they are not on dialysis. The elective or planned nature of live donor transplant offers a proportion of complex recipients the opportunity to receive a transplant, not possible on the disease donor list. Also, live donation through the UK live donation kidney sharing scheme may offer the recipient a better quality or better matched kidney than might otherwise be possible. We also need to say that clinical practice of live donation is closely regulated by the Human Tissue Authority through the Human Tissue Act of 2004. So we have to play by the book. Now, there are also the types of donation that are permitted by legislation include directed donation when there's a genetic or emotional relationship between the donor and recipient, or the paired pool, which when a donor A donates to a recipient B and donor B donates to recipient A, which is a practice common with the UK live donor kidney sharing scheme. The other type is that of non-directed altruistic donation, where you are allowed to donate to an unknown person on the transplant waiting list. And directed altruistic donation involves genetically related but has never met the recipient, maybe a distant family member that you've never met, or when there's no genetic or emotional relationship, but have only met the recipient on social media. Now, the key principles, ethical principles that we follow include altruism, in which case you say there is selfless gift without expectation or remuneration. When a person is also able to self-determine what they want to do, they are free to decide when they want to donate without any influence from somebody else or pressure or under duress. The principle of beneficence talks about actions that promote the well-being of others, which will be acceptable. And also the dignity talks about the human body or parts of the human body they are priceless. So there should be no monetary exchange. Non-maleficence means that whatever we do to donors, we should first do no harm. Of course, surgery can be harmful, so we have to make sure that we measure the risk carefully to make sure there is minimal surgical harm to the donor. The principle of reciprocity talks about providing benefit or service to another as part of mutual exchange. Now, in making sure that we do no harm to the donor, we have to, before we start the process, ensure that the kidney function of the donor will be compatible with normal living and lifespan after donation. We do this by checking the kidney function carefully and making sure that is acceptable and within the BTS or British Transplantation Society guidelines. We also have to assess the surgical risk and make sure it is not excessive, because we know donors are incredible people, I think, because they are taking a risk to their health by having surgery for the benefit of somebody else. Donation also, we have to make sure is free from coercion, duress, or pressure. We also have to consider the recipient to make sure that there is no risk or minimal risk of transmission of cancer or infection, as mentioned earlier in the previous talk. And also, when we do the whole clinical process, when we engage in all this, we do it in confidentiality to make sure that the donor and recipient are assessed separately. And we confirm that they understand the risk and benefit and are happy to proceed. We have to make sure that the donor is not influenced by the recipient in any way. We also have to consider the wishes and preferences of both donor and recipient, but we often prioritize donor safety and wishes. Legally, anybody can donate, any adult can donate. Well, how does it work in practice? The restriction on donation is mostly medical, for medical reasons. There's no legal restriction on who can donate. Now, healthy person with no prohibitive medical problems that significantly increase the risk of surgery or end-stage kidney failure after donation can donate their organs. We also have to make sure that the kidney function of the donor before donation is within the recommended BTS guideline, like I stated earlier. And we have to confirm that the donor understands the process of living donation after we've explained to them. They also understand the generic risk for all donors and specific risk for them. And we have to ensure that the adult donor is capable of valid, informed consent. Now, we have to also make sure that the donor does not suffer from serious mental health condition or substance abuse. And also, the donor that can donate has no recent diagnosis of or on treatment for cancer or serious infection. Now, there are some relative absolute contraindication to donation, which are mostly for medical reasons. For example, a donor who has type 1 diabetes will not be accepted as a donor, or a donor who is on 3 agents of blood pressure tablets, or who has end organ damage. Like if you had a stroke following hypertension, or you have some damage of the eye because of hypertension, we will not accept the person to donate their organs because of fear of end-stage renal failure after donation. How about the recipient? We have to ensure that the recipient is happy to receive a kidney from the donor. Some recipients don't want to receive live donor organs. And we have to make sure that the recipient has no prohibitive medical problems. And like stated earlier, the estimated kidney function has to be less than 15% at the time when the live donation happens. And also, the recipient has to be able to understand the risk and benefit and can give valid, informed consent. The question of whether it's genetically or emotionally related to the donor is usually relates to when it's a directed donation. And again, the recipient does not suffer from serious mental health condition because it's going to be very difficult to manage. Now, there is also no recent diagnosis again or treatment for cancer or serious infection. Everything usually starts with the recipient. We have to make sure that the recipient is in a good medical condition before we start working the donor up for donation. Potential recipients should have a kidney function of less than 20% or thereabout, and that the renal team has to have confirmed that the recipient is eligible for kidney transplant. If not, there is no point working up the donor. Mostly because the some of the tests can be invasive, and the donor needs not go through those tests when there's really no point. And also, the recipient has already been fully educated about the whole idea of live donation and process and pathway to make sure that they are in a good position to inform family and friends about the option of live donor transplant to avoid dialysis. Preemptive transplant is the goal for all patients who can benefit from, because they do have better outcomes than if they are transplanted after starting dialysis for many years. And we also have to make sure that before we start live donor process, we have to make sure that the recipient has been confirmed to be medically fit for transplant. Now, what are the steps involved in the donor? They have several steps. They can be very complex, time-consuming, resource intensive, and some donors can find it quite frustrating because it takes forever, they think. It does take forever for some people. But we have to understand that the team is committed to follow agreed evidence-based protocol. We have to follow certain protocols, and that some patients find quite frustrating sometimes. It is straightforward, however, for donors without health issues, and within 3 to 6 months before the pandemic, a live donor can complete all the workup and be able to donate their organ. However, it can be more drawn out for those with issues, medical issues detected during workup, when there is a need to refer them to other specialties like urology, cardiology, and other gynecology and other specialties for advice before we proceed. Sometimes sorting out medically unfit recipient can cause significant delay and can make some donors feel quite frustrated because they have to put a lot of stuff they want to do on hold to donate a kidney. Now, I have to say that the live donor coordinators, they keep the wheel turning. They do most of the work. They manage expectation from the outset and provide information and support throughout the process. I think for me, they are the key members of the team and probably the most important member of the live donor team. Now, we also want to say that there is policy in place to manage unsuitable donors, because some patients get really, really distressed by being rejected to donate their organs. And they need to be followed up with psychological support and also health support, so that they can live very well after being found unsuitable as donors. Now, in practical terms, what happens when a donor comes forward? Now, the donor usually calls the live donor coordinator first for an initial chat, just to say, I want to give my kidney. The donor coordinator will find out who do you want to give your kidney to, and then they will send them a donor health questionnaire, which they will complete and return to them. The live donor coordinator will now arrange a face-to-face meeting, to talk about, donation, to provide education about the pathway for live donation. They will also discuss the UK live donor kidney sharing scheme if it's relevant to the patient. Now, they will also obtain written consent for virology and HLA matching and a host of blood tests, including blood group, renal function tests. Now, blood group has to be done early so that we'll know whether the donor and recipient are blood group compatible. And if they are not compatible, then we're going to take them through the UK live donor kidney sharing scheme. Some may have, we have to be looked at closely and see whether it will be possible for them to have ABO incompatible live donor kidney transplant. Now, after the results are collated, they will be reviewed by the live donor coordinator. A psychosocial evaluation will be performed if indicated, and the live donor coordinator will refer the patient to the nephrology consultant, who will arrange a face-to-face assessment. He will take some history from the donor, will examine the donor. He will discuss the results of all the investigations that have been performed, will assess the risk of donation, and he will decide whether he thinks that the patient, the donor, can donate. However, the final decision as to whether the donor donation can go ahead will be made at the live donor MDT meeting, where the donor and the recipient will be discussed, including all the results and all the medical history, social history, and the final decision is made in that meeting. We also have what we call a live radiology live donor meeting, where we decide which kidney will be donated. In this meeting also, we look at the chance that there is any other pathology on the scans to make sure that we don't miss anything. And if there are any problems, we refer to the appropriate specialty for advice. After the live donor MDT meeting and radiology MDT, the patient is referred to see a surgeon, face-to-face consultation or by virtual meeting. Now, the surgeon's duty is to explain the technique, the surgical operation, and also especially the complications which are associated directly with the surgery, and problems which are also may arise from donation, which is not directly related to the surgery. We manage the patient's expectation. We talk about follow-up, recovery, And also we'll talk about, COVID. We have we do what we call COVID consent, talk about the risk of contracting COVID in hospital and after donation. We discuss the independent assessor meeting with and make sure that the patient is fully aware of the next step forward. At that time, the life donor coordinator will have given the patient the HTA and IA leaflets. HTA is Human Tissue Authority. IA means Independent Assessor. An independent assessor job is to look at the patient, the donor and the recipient, to assess that the relationship that has been claimed, and to make sure that the patient is making decisions independent of anybody or any influence, and that they understand the risk and benefit of the procedure. The independent assessor will write a report and will send to the Human Tissue Authority, who will look at the report and decide on whether they want to approve the donation and transplantation going forward. The transplant will not happen until after the HTA approval has been received. After that, the supplementary investigations may be required. A surgery date is agreed, and the enhanced recovery pathway is started. The donor is referred to the surgery school, where they will be educated about what they need to do or what we are going to do for them to optimize their recovery, so that they have very little issues after donation. This will be followed by a pre-operative anesthetic review to look at the risk of anesthesia. And at that time, the pre-op nurse will take blood for pre-op tests. And this is usually done within 7 to 10 days from the date of the operation. The final HLA cross-match will be performed, and this will be followed by the donor recipient surgery. The donor is admitted to the ward a day before surgery. The surgeon comes in to consent them, and the patients are provided with some information about what's going to happen. They have the routine medications to prevent DVT, for example. And the anesthetist will come to assess them in the morning before they go to theater. Theater usually between 8 and 8:30 in the morning. The donor goes to theater first. The surgery is done laparoscopically, and we do 2 techniques in Manchester. There is retroperitoneal laparoscopic donor nephrectomy, and also the hand-assisted laparoscopic donor nephrectomy. There's no big difference between the techniques in terms of early results. Now, post-op, after the surgery, the patient, the donor, goes back to the ward to be looked after. Most patients will stay on the ward between 3 to 5 days after surgery and will be discharged home. And there's possible risk or complications, but most of the time, patients do not have any problems before they are discharged home. Now, they are seen again in the surgical outpatient clinic 6 weeks after donation. Now, with COVID, we are now arranging for patients to choose to virtual review if they choose to, or face-to-face review. I'm finding a lot of the patients prefer virtual post-op review because they don't really have any problems or issues to talk about. And because the outcome of the operation is quite good. Now, After the virtual review or post-op review, the annual follow-up review is undertaken at the local hospital or at the transplant center. Or we are committed to making sure that all our live donors are reviewed at least once a year. What do? We want to provide regular health checks, do their blood pressure, take their urine checked, do their kidney function, ask them about their diet, exercise, and if they need or require additional support, ongoing support after donation, or if they have health issues, we assist them as much as we can by sometimes managing the problems, the issues ourselves, or referring them to appropriate specialties for support and treatment if necessary. Now, in summary, I want to reiterate again that live donor kidney transplant is a treatment of choice for patients with end-stage kidney failure, offering optimum patient and graft survival. The donor is evaluated according to agreed evidence-based protocol and with MDT input and discussion. And the investigations are performed in a logical sequence, although can be time-consuming. Now, careful preparation, selection, matching of the donor-recipient pair is aimed at achieving the best outcomes for both the donor, recipient, and their families. Donation, we have to remember that donation happens following valid donor consent, but transplant happens following HTA approval. The appropriate management of donor expectation is an essential part of the process. And donor follow-up is aimed at reducing the risk of unwanted consequences of donation. And all transplant centers will have a policy in place to manage unsuitable prospective donors. Thank you.
Fantastic, thank you. I think there are a number of questions that I think that have popped up during your talk, Tunde. I think Tess will sort of go through those with you.
Yes, happy to do that. Tunde, thank you so much indeed. That was very clear. There were a couple of questions relating to assessment time, which for example, somebody who's asked particularly about how long it takes for the assessment. I don't know if you can comment on how long on average it should be, or whether there is a target time for the assessment process.
Yeah, for the assessment process, actually, like I mentioned earlier, if the donor is straightforward, that is, no additional medical issues, no problems, no significant psychological, social, or any other problems, issues to address, it takes between 3 to 6 months to assess them and get them ready for donation. That's prior to the pandemic. Now, the pandemic has caused a little bit of some delay in the process. So it might take between 6 to 9 months to assess. But if the donor has got significant problems or issues that we need to look at, especially when we need other specialties to input. If we need input from other specialty, it can be a bit long. It can take longer than that. It can take a year, sometimes 2 years to sort out all those issues, because we have to make sure we sort out those issues before we tackle or before we perform the transplant or do the donor surgery, because donor safety is crucial. So the other point which I made earlier is also how long it takes sometimes is determined by the recipient, because some patients who are on dialysis may become suddenly ill without any warning, and that may delay the donor donating. It may delay a lot of it. So we have to sort out the recipient first before we can go ahead. And sometimes we may have delays up to 6 months just from the recipient side or longer. We have to make them better first before we can go ahead. I'm also reading something here. I'm not sure where. Say my father wants to give me one of his kidneys. He's 70 years old and lives in Hungary. How does it work logistically? It might not be a question for you. Who will answer the question? Yes, just a quick one. If you just contact your live donor coordinator in your dialysis center, that will be sorted out. There is a clear pathway to do that. I think
there were a couple of questions relating to nephrectomy and transplant, not strictly living. I mean, it may be a living donation involved as well, but so if somebody's had a nephrectomy, either one or bilateral, how long typically to wait to get on the transplant list?
Get a transplant. Yeah, if you just had a native nephrectomy, the average time we say about 3 months. If it's not a big kidney that you removed and you are pretty well without other associated conditions, between 6 weeks to 12 weeks, that's what we will say you can have a transplant. But you have to be fully recovered before you have another operation generally. So that's what you say. And also if you do not have any complications as a result of the nephrectomy.
Thank you.
Now, as a potential donor on average, how long is the recovery period? The recovery varies widely. For most people, it depends on what you do. If you are self-employed and you work on your own, you work from home, and I think you'll be ready to go within 6 weeks of having a laparoscopic donor nephrectomy. If your job involves very strenuous manual work, you have to wait for about 3 months before you return to work. So it depends on you, but you'll be ready in 6 weeks for most people after laparoscopic, if there are no problems.
There was a question about the rules for pooled donations.
Yes, the rules are for you to get onto the pooled donation. Of course, there should be a reason for going there. The reasons are usually because you cannot have a directed donation. Maybe your donor is not compatible by blood group or HLA incompatible, or you have positive cross-match. So you go into, the donor has to be acceptable to donate. First of all, he has to be well and acceptable, and we have to make sure that the kidney function of the donor will also be acceptable to the other party. And we also make sure that of course the recipient is ready to receive a kidney. And that's how it's done. And they are pooled, the information is pooled and is done nationally by the UK Transplant Service. And the matching run, I think we have it about 3-4 times a year, where we pool the patients and decide who can donate to who. That's how it works.
Thank you, Tunde. Most of the other questions can probably be answered by Hussein later, or you've covered them already in your talk. So Given it's just gone 11:20, I'd like to thank you very much indeed. And we will now take a short break until just after 11:30.